Welcome back to the Changing Landscape of Hemophilia Management, presented by Albert Einstein College of Medicine of Yeshiva University at OMed Live. Our last session today is entitled Addressing Comorbidities and Long-Term Complications in Patients with Hemophilia. My name is Sue Cutter, and joining me to discuss this important topic are Dr. Eric Hume and Dr. William Matthai. Today's session is an interactive live program that allows us to take questions in real time throughout this presentation. I encourage you to send us questions at any time throughout the course of the program by typing them in the box located at the lower left-hand side of your screen. I'd now like to introduce our two faculty members. First, I'd like to welcome Dr. Eric Hume. He is Associate Professor of Clinical Orthopedic Surgery at Penn Presbyterian Medical Center. We're also joined this afternoon by Dr. William Matthai. He is Clinical Associate Professor of Medicine at the University of Pennsylvania and Interventional Cardiologist at Penn Presbyterian Medical Center. Welcome, Drs. Hume and Matthai. I'll now turn the program over to you, Dr. Hume, to begin our discussion.
Thank you. Welcome. I'm going to talk, I'm an orthopedic surgeon and specifically interested in hip and knee problems, but do general orthopedics with the Hemophilia Treatment Center. So today we'll talk about predominantly the main target joints being the elbow, the knee, and the ankle hindfoot. As we finish up, I'll talk a little bit quickly about some of the other joints. The real issues tend to be the functional needs that I supply the support to the Hemophilia Treatment Center. The factor prophylaxis, prevention is the key, is run by our hemophilia group. I get involved with the care after there's been a bleed in the joint, get involved in the decision for synovectomy and for surgical reconstruction. So we'll run through those things initially in sort of a general overview about how to think about the joints, but then I'll go back and specifically talk about the elbow, knee, and the ankle. The key, as I kind of alluded to a minute ago, is the teamwork connection. The reason the Hemophilia Treatment Center works well is that I, the hematologist, the physical therapist who I work with, the staff in the Hemophilia Treatment Center more broadly, Sue, my buddy over here, and the hospital are all committed to the process to take care of these patients. And the teamwork connection is especially important connection. The pathophysiology you've heard about earlier, and so I'm going to just quickly touch upon it. We know from clinical observations that recurrent bleeds into the joint lead to joint destruction. Is iron an important part of the problem with the direct effects on cartilage and synovial proliferation? Is it the synovial response with the multiple cytokines that are released? Is it the polymorphonucleosides that show up later on and release the lysosomal enzymes? And then the recurrent process of having a synovitis that causes recurrent bleeding just keeps the process going on and on and on. So if the problem is recurrent bleeding into the joint, then prevention is the key. These two articles on this particular slide would be the right articles to have in your library in relationship to the orthopedic care for the hemophilia patients. Both recent reviews, both very nicely balanced reviews. So if you're going to look up any of the literature in my talk, these are the two that I will encourage you to do. And they go through the prevention, the recommendations for the treatment of acute bleeds, synovectomy and surgery in a broad, well-balanced way. So let's go ahead and get started with prophylaxis. One of the issues over the years have been the ounce of prevention or the pound of cure. Do you treat the joint bleed once the person has had the prodrome, they know the bleed has started, or are you better off preventing the bleeds entirely? The two references on this page, one's a very old and probably one of the most important references with long-term follow-up from Sweden, showing that in a group of young men that the prophylaxis was very important. And then more recently in the New England Journal of Medicine from about 6 years ago was a follow-up article to that, and both of them support prophylaxis very clearly. The factor management, again, you heard from Patrick Fogarty earlier about, so I'm not going to go into this. Simple factor replacement, alternate drugs, and the management of inhibitors are all important things that the hematologist and I understand when we're talking about the management of the bleed. One of the issues that is sort of regional is aspiration. The data is pretty soft whether aspirating the blood from a knee joint has any real long-term value. There are good precedents. There are articles out there that say, yeah, you ought to. And there are other articles that say that that's not as important as the prevention in a more general way. But the key, whether or not you aspirate the joint, is that the factor management has to be absolutely perfect for the time about the bleed. RICE is sort of the standard orthopedic care for everything, and I'll talk a little bit more about that in a second. The physical therapy component of it is very important. Back to what I mentioned on the first slide about function. Not only do you have to quiet the bleed down initially, but then you have to regain the functional status of the joint after the bleed, which includes both range of motion, and I'm going to say functional range of motion. We'll talk a little bit more about that in a minute, but also to regain the strength. The pain inhibition related to the bleed into the joint is very strong inhibitor of muscle strength. RICE. Rest, ice, compression, elevation. This is sort of the standard orthopedic care for an injury. One of the important things to remember that with the rest and immobilization, that the mobilization should be in the position of function, not in the position of comfort. One of the things that we see with patients coming to us is with knees with flexion contractures. You don't walk well with a flexion contracture about the knee. Flexion's a more comfortable position after a blade, but it's not a functional position for the long run. So in general, we put the knee in extension with a knee immobilizer. We try to put the foot and ankle at a plantigrade or a neutral position with some sort of a fracture boot. And we try to put the elbow at 90 degrees in one of the padded gutter splints. So again, with the knee especially, the position of comfort may not be the position of function. It's important to recognize that the position of function is really an important process. Ice has got some pros and cons. Ice is used routinely for pain control, but one of the issues that has been discussed, and there's not hard data for this, is that factors work best when they're at body temperature. So if you cool the joint too aggressively and you lower the temperature, the factors that have been put in may not be effective at controlling the bleed. I still like ice, but one of the things that will be interesting for the future is to know whether or not it's a contraindication. Compression is important. Compression not to the point of cutting off the blood supply to the arm or the leg, but enough to provide the external support that's required for tamponade within the joint. The soft bulky dressing that's supportive for the joint needs to go on before the immobilization goes on. And as I alluded to in terms of arterial and venous supply, the compression, the elevation can work together to maintain the venous outflow, but not to the level of elevation where the arterial pressure is too locally reduced. Locally reduced enough so that the tamponade becomes more important. And the other thing is that in general, if you lower the swelling with elevation, comfort will often come along with that. Synovectomy. So the person has had a sequence of bleeds. The sequence of bleeds has become more frequent because the lining of the joint has become thick, friable, and minimum trauma leads to an injury of the synovium, recurring bleeds, more synovitis.